So a lot of the techniques you've already heard from my colleagues so far in this session, so I may do a little less on that, but I will show you what I've got. So these are my disclosures. None of them will influence any of my talk today. So in the setting of PEG, you've heard a lot about the feeding indications, the sort of positive giving reasons of food to the stomach, all of those things. And the speakers have mentioned the idea of decompression. So as you know in the room, the malignant obstruction component of thing is usually that indication, and it's often a sign of advanced disease. That is almost always your sign of transitioning from active care management into that palliative setting. And the question really is how can you improve that symptomatic component to make the quality of life during that palliation, however long that's going to last, comfortable for the patient. So the idea of the PEG in this setting is gastric decompression. It relieves the symptoms of obstruction. It does not completely resolve them. It just improves them. And it allows for some of these other palliative care things to be accomplished, being at home, being with their loved ones, being able to travel, not being stuck with that lovely NG tube hanging out in the hospital bed for the rest of their life. As recently as 2003, we did not recommend people who had a life expectancy under 2 months have a PEG for decompression. I'm going to make the argument that that's not what I see, that's not what I do, so I think that's old advice. I don't know that that's necessarily true or fair, but definitely if I were sitting there with less than 2 months to live, I would want my PEG tube. So don't listen to that if I'm ever your patient. The PEG tube from a palliation perspective is very similar to all the techniques that you've heard. I am a giant component of wearing those lovely things that you probably last used for trauma, the giant booty covers, because as soon as you get a PEG tube in, you will often get a decent amount of backflow in these patients, even if they've got an NG tube in, even if their stomach was previously decompressed. So watch out for that component of things. It's, you've just opened the floodgate so that everything can come out. Also in this population, I think you've got to consider good airway protection. Anybody who's going into any surgical procedure with an existing bowel obstruction, you have to worry about a higher risk for aspiration. You've got to address that preoperatively if possible. The other challenges have been mentioned. Specifically, you have less working room in the abdomen secondary to that bowel obstruction. Everything is distended, everything is blown up. Some of the ideas for decompression, placing an NG tube prior to placement of your PEG by 24, 48 hours allows that to decompress. It also allows it to kind of be an electively scheduled PEG as compared to, hey, we need an emergency PEG. No such thing as an emergency PEG. You've got options for that. The other things that come up in these patients are specifically the malignant ascites. That can be in up to 63% of people. That's primarily in the GYN literature. So again, if you're not looking at a malignant obstruction from a GYN etiology as compared to colorectal, so on and so forth, pancreatic cancer, you may have a lower rate of ascites. And then the carcinomatosis and the peritoneal implants just create a concrete level, as you've all seen in open operations, to everything in that abdomen. So the gastric distension that you'd like to see does not always happen, and thus some of these extra adjuncts that you've heard about, using fluoroscopy, using your interventional guided radiologist if necessary for some of these things, can be very important in this patient population. It is a technically feasible thing to do, right? So 90% plus, we get the PEG tube in. The issue is that everybody who gets the PEG tube placed does not always get the symptomatic relief, and I think that's an important thing to discuss with your patients ahead of time. So many of them get improvement in their symptomatic relief, but almost all of them do not get resolution. So I thought the most interesting statistic I found in this was that it decreases the number of vomiting episodes from 2.2 times a day to 0.4. So you're not at zero, and obviously everybody in the room knows that the PEG is an anterior PEG. When they're laying on their back in the bed, propped up in the recliner, all of that lovely stuff is going to pool posteriorly. So it's not the best decompressive thing unless they're going to be leaning forward, draining over a toilet, letting that area decompress. But it does give them a pop-off valve, and thus improvement of those symptoms, being able to get out of the hospital. The complication rate in this population is a little bit higher, and specifically leaking around the stoma is associated with that rate of higher ascites that you saw earlier, and thus something like that may just be a preoperative education. Most of those are not, in my opinion, things that are going to require significant intervention unless you're getting to the point where your ascites are super infected, you got peritonitis, so on and so forth. But teaching them how to deal with that before the PEG is placed may alleviate a number of those phone calls to your office. In terms of timing of PEG, I think this study was important because it looked at 429 patients who were undergoing PEGs for palliation only. And what they really found were that the interval of time between the PEG placement did not change your survivability. So some were pegged early, some were pegged late in their course. That didn't change their overall survival. So what their recommendation was to take away that if you're gonna place a PEG, go ahead and do it early. Get all of the benefit that you can from alleviating those symptoms and let those patients have a better quality of life. And again, big picture on survival, most of the time, as I mentioned, this is the transition from treatment to palliative treatment. So you're not looking at aggressive clinical trials, you're not looking at cure anymore, you're looking at comfort. Average survival somewhere just over 2 months, depending on which study you're looking at. Some people did receive TPN, that did not impact their survival. There is a very small group of people, and that is primarily looking at it in the ovarian cancer literature. They seem to have very chemosensitive tumors who got chemotherapy administered after their PEG placement, so staying in that active treatment group instead of going to palliation, sort of that last-ditch chemo that you hear a lot of patients wanting and some medical oncologists being willing to give. So about 14% of people with their PEG did have clinical response to that chemotherapy, thus resolution of their obstruction, thus moving on to PEG removal. But the majority, the 15% that did not have that resolution, died at home or under hospice care. They got out of the hospital, they got to go be with their family, they got to go have the rest of their life the way they wanted. So predictors of shorter survival, liver mets, older age. So my take-home messages, and I'll keep it short and sweet since I know we're getting kind of close to time at the end of the session. PEGs for decompression are technically feasible. They do have these associated conditions such as the ascites, the carcinomatosis that can modify your procedural techniques, but most of those are overcomeable with a 90% plus success rate of placement. I think it's important to educate on your symptomatic improvement. Again, 65% get improvement of their symptoms, but very few get resolution of their symptoms. However, if their goal is to get out of the hospital, spend their last 2 months in a place that they would rather be as compared to in the institution, I think this is a very reasonable thing. And if you're gonna place a PEG, consider placing it early. Does not impact your overall life in terms of survival, but can obviously improve those symptoms for the time left that you have. So, thank you very much. These are my residents who love doing PEGs, by the way.